Good evening, everyone. Today is January 19th, and some of you are aspiring for the upcoming foreign medical graduate exam in the June. Some of you are approaching the AIMS May 2020 June, and some of you have big dreams, big plans for the NEET PG 2021. Good evening to see Vasudev, Rajat, Asper and many more. Just I wanted to take a 10-minute brief session. Polycythemia rubra, one of the favorite questions both in pathology and also in general medicine. Nowadays I am falling in love with handwritten notes because that brings more personal touch in order to explain. I can sit with you like a classmate and we can be able to discuss. Now, how to revise this topic just in 10 minutes? That is the important challenge. The main clinical feature, how does the patient clinically present, is with the increased blood viscosity. Because of that, there can be hypertension as a presenting feature, erythromelalgia. Typically, the patient will get a ruddy complexion due to the polycythemia rubra. There will be transient visual disturbances. Because of that hyperviscosity, there is a decreased blood flow, and that can lead to development of transient visual disturbances. Then increased RBC turnover. Obviously, every time RBC is breaking down, that lead to DNA metabolizes to form uric acid, and that lead to development of gouty arthritis, can be the presenting feature. Aquagenic pruritus. That means patient will say, hey doc, whenever I take bath, I am developing this intense itching. So that is aquagenic pruritus. Why does it happen? So basically polycythemia rubra is a myeloproliferative condition. So it is not just the RBCs, even WBCs, platelets, they also will increase in number. So there is an increased mast cell population, mast cells. Mast cells in turn will release histamine. There is a basophilia in a case of polycythemia rubra. Because of that high histamine levels, every time he takes bath, he develops the pruritus, which is called aquagenic pruritus, is what you need to remember. Now, polycythemia rubra is a myeloproliferative condition. As I told you, platelets are increased in number, but they are not functional platelets. They are dysfunctional platelets. That is the reason bleeding can be the presenting feature. See what a paradox. On one side they have a thrombotic tendency, another side they also have a bleeding diathesis. You should always remember. Now, you know very well, these mast cells, these WBCs, basophils are releasing a lot of histamine. Excess histamine lead to peptic ulcer. On the top of it, there is a poor platelet function. Together will lead to increased upper GI bleeding. So sometimes patients can have melena as a presenting feature, and they may in fact present with anemia. So whenever a patient presents with melena, anemia, but he is having a high hematocrit, then you should suspect polycythemia rubra is what you need to remember. Right now, then there is a ruddy cyanosis, which lead to that facial plethora, and all of you know splenomegaly. Spleen is a organ for extramedullary hematopoiesis. That is the reason there can be development of splenomegaly in polycythemia vera, which is a myeloproliferative state, is what you should remember. Now, what are the lab findings? So every topic, there are totally 953 topics for the preparation to NEET PG, FMGE or any exam. In all the 19 subjects, every topic you should know like this, how to revise in 10 minutes before exam. The guy who is able to do that kind of a smart revision is the guy who is going to become the topper. Take it as my word. Now, doctor, there is an increased hemoglobin, leukocytosis, thrombocytosis, platelet count is high, a low erythropoietin. Very important. JAK2 mutation and polycythemia rubra vera, you should not forget. In fact, the diagnosis of the polycythemia rubra vera nowadays is revolutionized. If you are suspecting in a given case of high hematocrit in a myeloproliferative state, if you are clinically suspecting that it is polycythemia rubra vera, you need to order for a JAK2 mutation is what you need to remember. Then very important thing is normal oxygen saturation. For example, if the patient, let us say, he lives in Himalayas, high altitude, let us say he lives in high altitude. In Himalayas, he is a Maharshi. Or if he is a smoker, or if he is having any lung destruction, or if he is having cyanotic heart disease, that means right to left shunt, if he is having, in all these scenarios, there is a development of hypoxia, and his oxygen saturation will be low. That will stimulate the erythropoietin production, but that is not called polycythemia rubra vera. Don't forget. If there is an increased erythropoietin and polycythemia, that is not polycythemia rubra vera. What is that called as? Secondary polycythemia is what you need to remember. Then what is polycythemia rubra vera? Fundamentally, problem is with the bone marrow. In the bone marrow, there is increased production of erythroid precursors. That is called the primary polycythemia. Primary polycythemia, erythropoietin levels are low. That is very important. And oxygen saturation is normal. Secondary polycythemia, there is low oxygen saturation. Erythropoietin levels are high. That is how you differentiate primary polycythemia from secondary polycythemia, is what you need to ultimately remember. Now, doctor, you know very well what are the important lab findings. Now, what are the complications which can occur in case of the polycythemia rubra vera? It can lead to thrombosis, it can lead and myelofibrosis, because a myeloproliferative condition. And a patient can end in acute leukemia, which is a complication. How do you treat? Suck the blood, phlebotomy. If there is an increased risk of thrombosis, then hydroxyurea. And also, you may need to do a bone marrow transplantation in cases of polycythemia rubra. Now you are experts. Within 10 points in single page, how to do the revision, you know very well. Like this, you should prepare for all the 953 topics, doctor. Once more, I want to tell you, this session is more like, honestly speaking, an advertisement asking you, urging you to join our online mbbs.com video library, right? So we are starting our batch from January 26th, Republic Day, Sunday. So the plan is 45 Sundays. Every Sunday, morning 9 a.m. to 1 p.m., then a lunch break, 2 p.m. to 5 p.m. In Hyderabad, we have a face-to-face class. If you are not from Hyderabad, no worries. This becomes broadcasted into onlinembbs.com video library, right? And there is a schedule for this program, of this 45 Sunday program. These 45 Sundays are divided into 21 Sundays and 24 Sundays. January 26th to June 30, we have 21 Sundays. From June 30 to November 30, we have 24 Sundays. So we complete 19 subject revision according to a schedule, one cycle between Jan 26 to June 30, and second cycle from June 30 to November 30 in 24 Sundays. So you get a login for you to attend. If you are not from Hyderabad, you are unable to attend the face-to-face live class, you can be able to attend, and it is being priced at 10,000 rupees, the cheapest coaching you will ever get in the entire world. But we love to help more number of students. At the same time, we can't give completely free, at least to pay up the expenses to run the show. So 10,000 rupees, and you have 45 Sundays, totally 45 into 8, 360 hours of the live online revision, 2 rounds of revision of the 19 subjects. So please do call our helpline 9000868 in order to subscribe to this program and also inform your classmates to join. We are starting from January 26th, morning 9 a.m. To 5 p.m. Right now? Now, doctor, let us quickly go to the typical case that is asked as a NEET PG MCQ. So Asper is asking, sir, will we have access to other folder on online MBBS? You can give a call Asper and to our helpline. They will help you to customize to your budget and enable you to get the best advantage on the onlinembbs.com video library. Now, doctor, what is the kind of MCQ, clinical MCQ, that is going to be asked in the tomorrow's exam? Nowadays, NEET PG all has become clinically oriented question paper. So you should be ready to face a MCQ like this. A 62-year-old woman, right? 62-year-old woman presents with a overwhelming fatigue and headache. That is a very important clue. There is a blurry vision because of that hyperthrombotic tendency. She lost 8 kgs of weight. She says that it is extremely itchy after a romantic hot bath or a shower. She is otherwise very healthy. A blood smear shows precursors of the RBCs. And what you can see is a peripheral smear like this will be shown by the examiner, where you are able to see classically the packed film appearance, where you are able to see the segmented neutrophils and many thrombocytes. These are all thrombocytes, doctor. Thrombocytes. Many thrombocytes have been found. This is one way of asking the question in the tomorrow's NEET PG. Then a 72-year-old man presents with a painful fingers and toes. There is a burning sensation. What is that called? Erythromelalgia. Especially in the afternoon when the temperature is highest. He had similar episodes in the past, but they are resolving on their own. But today his fingers are particularly painful. And he reveals that he is fatigued. There are night sweats, regular headaches. A lot of times, doctor, headache sometimes can be one of the manifestations of a prothrombotic state, central sinus venous thrombus. He had a weight loss of 8 kgs. So this is a common part of the clinical vignette. His hemoglobin is 17. Oh my God, that is high. His erythropoietin levels are normal. Oh, that means it is not secondary polycythemia. And his peripheral blood smear shows RBC precursors. That means it is a myeloproliferative state. So this is how typically the erythromelalgia of the polycythemia rubra vera typically presents. Now, one of the common things that you need to know how to differentiate is, as I told you, hypoxemia, polycythemia rubra vera, smokers polycythemia, stress polycythemia. If you are dehydrated also, you can get polycythemia. Typically only it is hypoxemia, SaO2 level low. Whereas polycythemia rubra vera or ectopic erythropoietin normal. But if you look at the erythropoietin level, it is typically high if it is hypoxemia, which is leading to polycythemia. It is only of interest. Then in all these cases of polycythemia, whether it is secondary or primary, the RBC mass is increased. But in stress polycythemia and the dehydration, you can see there is a normal RBC mass, which is a very important clue. Then plasma volume is increased in rubra vera because actual RBC mass increased. Whereas smokers polycythemia, stress polycythemia stress polycythemia or dehydration, typically what do you have, doctor? You are having a decreased plasma volume, which is a differentiator. Right, doc? So all of you know very well now how to answer any question, anything about polycythemia rubra vera. I love to keep meeting you every day and add a bit of inspiration for you to study. Otherwise, onlineMBBS.com video library has 3,000 video lectures, but you need to get motivation to read. That is where I am, which I will be adding a bit of inspiration to you. And please don't forget to take an opportunity to subscribe to the onlineMBBS.com 45 Sunday 360 hours, 2 rounds of revision of 19 subjects just for rupees 10,000. Take an opportunity to subscribe. Good night. Enjoy a great studies and be on the track. Study every day. That is the only secret to become a winner. Have a couple of friends who are also seriously interested. I want to win kind of an attitude. Those who are having that, you should work along with them. Good night and see you once more tomorrow. Thank you.